Yeah, good afternoon, everybody. Also on behalf of my co-moderator, Professor Zani from Toronto, to this EUPSA ERNICA joint webinar on giant OMPHALOCELE. We have the pleasure of having multiple prominent speakers today with us, like Miguel Guelfand, Marlinde van der Kamp, Hester Langenfeld, and I start with introducing Dr. van der Kamp, and then Professor Zani will introduce Dr. Guelfand. So Dr. van der Kamp is a distinguished speaker with a special interest in research also. She is currently serving as a project manager for the European Pediatric Surgical Audit, and which is the official registry of the European Reference Network of Inherited Congenital Anomaly, or ERNICA. In addition to that project manager job, Dr. van der Kamp is pursuing a PhD in pediatric surgery at the Erasmus Medical Center in Rotterdam. Under the guidance of Professor Wijnen, who cannot be here with us today, her research is centered in the critical areas of pediatric surgery, such as abdominal wall defects, OMPHALOCELE, and intestinal atresia, aiming to contribute to insights and further advancement in these diseases. She underwent foundational training in Master and Bachelor of Medicine from the University of Groningen, and then the training was a general residency in Apeldoorn and a city called Zutphen. Yeah, so Marlinde, we are honored to have you with us tonight to introduce the research study you're doing on the evaluation of the non-surgical silo for giant OMPHALOCELE and how people treat that disease in Europe. Yeah, that was my introduction for you. A really big honor. And now, Augusto, please, do you want to introduce our second speaker?
First, so it's really an honor and a privilege to have Dr. Guelfand with us today. I've gone through your CV, and it is impossible to shrink it down in a couple of lines. Everyone knows you, of course, as a world expert in minimally invasive surgery, originally from Chile. You've been a pediatric surgeon, and in fact, the head in Santiago up until recently, when you moved to the Cleveland Clinic, where in fact you are the chief of surgery at the Cleveland Clinic in the United States. In terms of training, trained also in Europe and in Australia. So this is from South America, North America. This is really incredible to see how many continents, in fact, you've touched. So you're full professor of pediatric surgery at University of Chile, of Santiago in Chile before, and program director before. So as we can imagine, the skills that include not just education, training, as we said, interest in minimally invasive surgery. But I've seen also you have a degree from the School of Economics. So again, a leadership and business finance in at a different level. You have it all, Miguel. And of course, also a great scholar with a number of publications and in fact international presentations on different aspects of pediatric surgery. Again, I'm mentioning minimally invasive surgery, but of course how not to mention giant OMPHALOCELE, congenital anomalies and giant OMPHALOCELE, which in fact is the reason why we absolutely wanted you to be part of this webinar, because there's a lot of interest. We have more than 100 participants now. That you know, really looking forward to hearing about your technique to deal with this complicated form of abdominal wall defect. And so without further ado, I think we should start.
Yeah, so first of all, thank you very much that we have been given this opportunity to speak at this webinar. It's a great pleasure and a great honor also to discuss this topic. Besides the names that have been mentioned before, I would also like to introduce Dr. Hester Langeveld, who is a pediatric surgeon at the Erasmus Medical Center in Rotterdam, and who also has some experience with the technique that will be explained with a patient case that she will explain later on. She also achieved a PhD, and she has been working also before in South Africa, so she has a lot of experience also in pediatric surgery. I would like to use this opportunity also to refer to the previous EUPSA Ernica webinar that has been held on giant OMPHALOCELE, which was hosted by also the moderators of today, and Professor Saxena and Professor Wijnen. If you're interested in this, this will be a bit more in depth about the treatment of giant OMPHALOCELE, outcomes, and also on a specific surgical technique, which is the component separation technique. So you can find this also on the YouTube of the EUPSA. And I put the link also here on the slides. And here is a quick overview of what you can expect in the previous webinar. But without further ado, I would like to give the word to Miguel Guelfand to explain the technique of today.
Thank you very much, Marlinde, and thank you everybody for the invitation. Augusto and Martin, thank you very much. I really appreciate this opportunity and appreciate to be among friends. So thank you for that. So let me get about 3 minutes before the presentation, but how we get here, or how I get doing this. About 7 years ago, a baby was born in my private hospital, weighing 800 grams with a very severe congenital heart disease. And basically, anytime you touch the baby, he wanted to die. That's it. So obviously, we need to do something. Usually, you'd use a surgical silo at that time. It was impossible to do that. Start talking about people. Any ideas to treat this in another way? Because we hate, paint and wait. And we used to use a surgical silo on all these patients with very good results, by the way. Until I talked with Dr. Pistola Abelo from Colombia. He's an amazing, very, very smart surgeon. And he came with this technique that we modified a little bit. But basically, he was the one who started with this about 20 years ago. And we treat the baby amazingly with no problem. And since there, about 7 years ago, we haven't gone back. This is for us was a game changer in terms of how to manage this patient, and the outcomes are really amazing compared with the other, pain and wait and surgical silo. And that's why we published at the end about 2 years ago our experience in that. So obviously, I'm not going to go to the backgrounds, but basically, it's a very this giant OMPHALOCELE is a very severe congenital malformation. Obviously, there's sometimes there are combined malformation that obviously have different outcomes. But usually, just to talk about the giant OMPHALOCELE itself, there was no protocol nowhere. Everybody was doing something else. And we tried starting this. We tried to do a very strict protocol that we started about 7 years ago, and all the patients were treated exactly the same for the last 7 years in that series. Next one. Thank you, Marlinde. And as I said, usually, obviously, giant OMPHALOCELE is defined as an OMPHALOCELE that can be closed as a primary closure. And there's 2 ways to see it, or they have more than half of the liver outside, or more than 5 centimeters. It depends on the weight of the baby, basically. But usually, the manager was or do a surgical silo, put some biomaterials, pain and weight that everyone knows, tissue expander. So again, there was no formal protocol for that. To deal with those patients in any part of the world. Next, Marlinde, please. And this is it was done, 2-3 years ago. And we start doing this technique that I'm going to show after in all the babies, independently of the weight and the comorbidities that they were born with. And it's a very simple thing to do. Is basically making a non-surgical silo with duoderm. That is obviously is a hydrocolloid dressing, and we'll see in the next slide. But basically, almost 98% of the patients were closed primarily within basically 2 weeks. The thing about these silos, first, only the most amazing thing is it requires only one surgery in 98% of the patients. You can progress depending how the baby is doing with the we'll see the reduction of the silo, but basically it's a very simple, very controlled technique in terms of how to progress in the reduction of the silo. Next one, please. And well, hydrocolloid duoderm is reduced in basically from wound care, plastic surgery, and we took hydrocolloid because it's a very flexible material. It's very easy to put into the silo and change it, but we need to do it very often, and it's very cheap. So that was a perfect dressing material. The only thing is we'll love to have a very transparent material. Actually, I'm talking with a Brazilian company that we will be able to maybe develop the same quality of the duoderm, but transparent, so we can see exactly what's going on beyond the duoderm's dressing. Next one. And this is very simple. Once the baby is born, one of the key points is that you have to put the silo as soon as possible. You don't have to do an exit procedure, that's for sure, but basically as soon as you put it, because the thing you don't want to get is that the amnios get dry. That obviously facilitate the reduction of the OMPHALOCELE for sure. So basically, you shape a T in this duoderm. This is a 20 by 20 centimeters, 8 by 8 inches duoderm. That is the thick one. There's a thick one and a very skinny one. This is the thick one. It's called GRF. So you cut a T shape in the dressing. Next one, Marlinde. And the part of the T that goes down goes to the skin of the patient. That's why you have to get the abdomen very clean and very dry. Attach the T to the skin up to the level of the amniocutaneous level, and then you wrap the OMPHALOCELE with both flaps, around the OMPHALOCELE in both ways, from the left and from the right. And then you put the extra duoderm just to secure that the silo is attached very secure. One of the key things is that not all the times the umbilical cord is the apex. So you have to be careful. First, don't put any of these plastic clamps on the cord. Just replace it for a suture or elastic band. Don't keep these plastic wedge clips for the cord. You need to replace it, and usually you have to put the apex of the OMPHALOCELE in the apex of the silo, and usually that's not the cord, by the way. So you can see this is the first. It's a couple of hours after being born. You can see that the silo is whole. Basically, that the thing that go across the silo is a tongue depressor. The wooden tongue depressor is very cheap. And those strings is just to, we're not doing any traction. It's just to, compensate that the OMPHALOCELE sometimes is very high. It turns to the right or the left. So this is just to stabilize the silo. Next one, Marlinde, please. And then every other day or every day, depending on the condition of the patient, you reduce this by half inch, 1 centimeter. It depends how the baby is doing from the respiratory point of view. But we keep this patient at the beginning. We keep the patient completely paralyzed and intubated for the first, I think, 2-3 years of the use of this protocol. But then the last 4 or 5, we changed the protocol for just a sedation. The baby is intubated, he's sedated, but we only use paralyzation for the reduction of the silo. That obviously have the baby in better condition, less edema, and from the respiratory point of view, they manage much better. So usually between 1 and 10 days, you come from the first picture that you remember to this one. So the silo is completely flat already, and there's nothing else we can do from that part of the silo. So we change to the next stage. The next one, Marlinde. So that's day 10 on the same patient, by the way. Next one. And then we call what is called the amnion inversion. So basically you depress into the cavity the amnios, and you get together both of the amniocutaneous edges, and you secure it again with the duoderm. This basically is to see how the baby will cope if we go to the OR and try to do a primary closure. And you keep that's exactly that position for 1 or 2 days, see how the baby, respond to that closure. That is not a closure actually. And then you decide to go to the OR or not. Next one, Marlinde. And then you go to the OR, and usually in 98% of the cases, we have done this as a primary closure. In about 2 or 3 patients, we put a mesh as a reforcer, or in one case, we put a Gore-Tex mesh just to close it. We have done always, in some cases, component separation to achieve a primary closure, but usually 95% of our patients are done by primary closure with an anatomical closure with no problems. Next one. So this is basically the results of this is for 50 patients. We have already almost 60 in this group, and the median weight was 2,900, the standard weight 38, and almost a third of the patient has an associated anomaly as a congenital malformation or congenital malformation, etc. So the median silent reduction time was 5 days, the time from amnion inversion for 5 days, and to closure for 12 days. And as I said, 95% of the patients achieve an anatomical closure. We have some complications like hemoperitoneum, and this is because the amnion was a little too dry. We put this silo in day 3 or 4 because the patient was referred from outside our city. 3 patients have local infection that was treated with antibiotics, and 1 patient has a high intra-abdominal pressure that basically the thing about this, you retrieve your reduction 1 centimeter up, and the baby got better in a minute. And a central line infection that is not really related to this treatment. And there was no mortality related to the silo. There were 4 mortalities related to another malformation with each patient. Next one, Marlinde. Oh, I think that's it. So basically, since we start 7 years ago, this for us is a game changer in terms of the management, not because it's very simple and I can say very cheap. It's because the patient are managed much better. You avoid many surgeries, the complication of the surgical silo. You obviously avoid the pain and weight that is, for me, is horrible. And this in our series is about 60 patients already. I think we haven't had any major problems, and we have developed a new protocol in terms of how to manage the patient within the ICU in terms of sedation and paralyzation that basically makes the management much better for the neonatologist. Thank you.
Thank you so much for this explanation. There was a great explanation of the technique. I wanted to take over the next part to tell you all a bit more about the research that we would like to perform with this technique. So this article was published in 2020 in the Journal of Pediatric Surgery, and of course it didn't go unnoticed also in Rotterdam. And there was great enthusiasm about this technique and about the promising outcomes of this with a reduction time and closure time of average of 12 days, and also 95% of cases of patients that reached anatomical closure. So in this research project, Dr. Hester Langeveld is involved, and also Professor René Wijnen, who is the head of the Department of Pediatric Surgery in Rotterdam, And we're very honored and happy also to work together with Professor Miguel Guelfand as well on this research. So how is this going to work? We would like to evaluate this non-surgical silo technique in Europe. And this is done firstly by the clinician in Europe that decides to use this treatment. So the treatment decision is made by the clinician, but a clinical protocol is provided on the platform of Stay Current. Also, of course, the article is very explanatory as well, but this clinical protocol can be used. But of course, you need to obtain informed consent also of the parents for data collection. So this informed consent file will be provided by the research team. And at the end of primary hospitalization, a questionnaire will be filled in by the clinician in a center in Europe. This questionnaire will be provided by us as research team, and this is also via Castor, which is a platform that is used. The data analysis and inclusion period will be 1 year, and afterwards, retrospective data analysis will take place to eventually aim at a scientific publication. So we hope to include as many patients in Europe as possible to analyze this and see if this is actually a feasible technique that could be used as a golden standard in giant OMPHALOCELE. The research outcomes that we would like to follow are the primary outcomes are flat silo reduction time, as explained just before, amnion inversion time, and eventually, of course, surgical closure time for these patients. And these will be measured in days. Secondary outcomes, which are also important to measure, are length of primary hospital stay, mortality, complications, type and duration of ventilation, and also whether antibiotic treatment was given and the duration of this. And also if parenteral nutrition support was given and the start of enteral feeding. And we will all measure these in days as well. Of course, to start such research, we need ethical approval. So a research proposal has been submitted at the Erasmus MC, and we're still waiting for approval, but we are in the process of finalizing this. This template can then be used by other centers in Europe as well to also apply for ethical committee approval, and then afterwards, data transfer agreements are necessary to transfer the data and collect the data of multiple centers in Europe. But if you are interested in this technique and you think you will use this technique and would like to participate in data collection, then you can pre-register now. This can be done by scanning this QR code. This will generate an email which will be sent to our email account. So we can reach out to you once the approval of the ethical committee has been made. So once again, these are all the participating researchers, and we're very excited about this project. So if you would like to participate or if you would like to know more, you can always reach out to me or to one of us. Then next up, I would like to give a bit more information also about the guideline development of OMPHALOCELE. In the European Reference Network of Inherited Congenital Anomalies, short also called ERNICA, we think it's very important to look at quality of care as an improvement cycle, because improvement of quality of care is of course not a straight line, but we think it's more of a cycle. And to reach this goal, to improve quality of care, we need to look at different components of the cycle. So not only by measuring quality of care via, for instance, a registry, the EUPSA registry, in which I am also a project manager. This is not only important, but also the development of guidelines and also the implementation to make sure that once these guidelines are developed, they are also actually used in clinical practice. So how do you actually develop some sort of guideline? First of all, of course, it's very important to know what is currently practiced, so to evaluate the clinical practice. This is done by exploring and understanding practice variation, but also by identifying knowledge gaps and the need for guideline updates. Then afterwards, you can fill these gaps by performing research to eventually describe the desired level of care. For this process of Ernica guideline development, and specifically now we are working on the OMPHALOCELE guidelines, we use an evidence-based method, and a clinical expert panel is also consulted, because especially in pediatric surgery and in rare diseases, also expert opinion is very valuable. So 11 PICO questions have been drawn together, and these are categorized in prenatal and postnatal care, and also in closure of the abdominal wall. We are very lucky also to have a methodologist working on this with us, who is very experienced in the development of guidelines of rare diseases, and her name is Willemijn Irvine. And after and during this process, we will also work together to look at guideline implementation. And we have a guideline an implementation specialist in Ernica, and this is Olivia Spivak. And yeah, that's the process that has been going on until now. So this is a bit of an update on the research that has been going on in Ernica. Yeah, we're very excited to work on all of these projects. So next up, I would like to give the word to Dr. Langeveld, who is going to tell us a bit more about one of the patient cases in Rotterdam.
Yeah, so I'm Hester. Welcome, everybody. Very nice to see so many people interested. I saw Miguel Guelfand talking on the Handrun project. I don't know, it was, I think, like 6 months, maybe 1 year ago or something. And it was, for me, it was a game changer to see this technique. We do not paint and wait, but we give a silicone sheet and then just wait and do Ramirez. And it always takes such a long time for the children to be in the hospital. So I went, after this talk, I went to the head of the department and I said, we really need to do this and we need to change our technique. And I was really excited. And then we had to wait a very long time before the first baby was born with a giant OMPHALOCELE. They don't come that often. And so we had to wait a long time. So we were really excited when the baby was finally born. Maybe we can go to the next slide. And this is the baby we're talking about. She's still in the hospital at the moment. And we had some struggles. Actually, in the end, we could not close it. So I want to show you how we did it and what our struggles were, and talk about it for the discussion. Because I think we did some pieces, we didn't do it optimal. We could have done it better. So I really want to share this and learn how we could could have done it better. So this patient is a female patient. Antenatally, she was diagnosed also with cardiac defect, but that was not the problem after she was born. She was born at 35 weeks, 2,400 grams, and she had a giant OMPHALOCELE with liver, stomach, small bowel inside for about 8 centimeters. So here you can see some pictures of this baby. And on the next slide. So she was intubated after delivery. She had quite a good start, actually, good EPCAR scores, but then she decelerated a bit and she was moaning a bit. So they intubated her and brought her to the ICU. So then we came in really excited to finally start the technique. We had the duoderm, we had it in the hospital, everything ready. So the first struggles were, you were talking about it, this a little bit, Miguel, about the umbilical cord. There was a first struggle, what to do with the umbilical cord. We had it very long, so as you can see, but then it would be between the tongue depressors. Should we do it in between or not? So we've decided to cut it down a bit and put it under. And then then we put the tongue depressors on, like you see, and we were very happy. But the difficult part for us also was with the silo bags for gastroschisis, they are transparent, is what you told also. And this is not transparent, so you don't actually see if there's maybe some small bowel in between your spatula or not, but you can quite feel it when you touch it. So, and the amnion is quite thick. So I don't think you really, that's not a high risk, I think, that you put it in between your tongue depressors, but still it was you had to get used a bit to the feeling. Okay, and then, how much pressure? You said you have to measure bladder pressures. So we did. It was 17, and now it should be under 20. But she was also urinating a bit beside it. So was this good or not? But okay, we accepted that. It was quite. We put some pressure on it. It was the bulging a little bit, the duoderm on the side. So it's okay. It's okay. So next slide. So and then the spatula moved a bit. As you can see, so on the liver side, it went a little bit up. So it was horizontal, and now it's a little bit up. It was also because we put the tape around the spatulas at the end, but if you push quite hard with the tape, the middle part is distending. So it could move a bit. So we were, had some troubles with that. And we saw the duoderm bulging when we pressed down. Is that okay? Or do you bulge it on the side and it's not too much pressure to go inside? So we were also questioning that point. And then the next one. And then on day 5, we took it off to clean everything. It had a yellow appearance, but it didn't look infected. Actually, it looked very good. We made the umbilical cord a bit smaller because it was a very smudgy thing and wet, and we made it a little bit smaller. And then we did the new duoderm around, and then we said we need to do something about the tongue spatula. So we now used the brown tape. It's a little bit more firm, and we attached it to the duoderm in the hope that it will not go up again, but will press down more. And then you see in the next photo, we added some more brown tape to the duoderm, and it was leaking a bit. So we put more duoderm on the baby, on the skin. So when you see in the fourth photo, you see the skin is a bit wet. So the amnion leaks a bit. And we did some cultures. We thought maybe it's infected, but it was not. We never had a positive culture from that. Later we have one, but not in the beginning. So, but we were still quite happy, and then went on like this. And then we said we also thought, what's the best way to clean the seal? Because when you take it off, it's a bit smudgy. So we took some sterile gauzes and sterile water and cleaned it, but we were not sure if it was necessary, or maybe there's better ways to clean the seal. So that was also one of our questions. And then the next one. This was the part where we thought, we were pressing and nothing happened really more. Can we already start with flattening or not? So we had a little bit of discussion for that. And that was already on day 12, and we had the baby fed with IV line, dus with the parenteral feeding. And everyone really wanted to start enteral feedings. So we decided to start some enteral feedings via a nasogastric tube. But still the defect was quite large, and we thought if primary closure would maybe a little bit hard, so we decided to do Botox on day 15. And then we decided to make it more flat. So we changed, and we put the duoderm a little bit different on the stomach, as you can see in the picture. And all this time the baby was ventilated, but we did not paralyze. We only had her on the ventilator, and CO2 was always high, like 8, 9, 10. Okay, next slide. And then we did have an infection. So it was an serratia, but she was not sick from it. We only had it on the skin, on the seal. We didn't start any antibiotics, and she didn't become sick from it. And what we also noticed was some erythema of the skin. We used some swabs for that, and actually that healed quite nice. We did try to invert at this point, but then her legs turned blue, and she was tachycardia, and her CO2s raised to 12 or something. We thought, no, we cannot close this. And that was day 23 to 30. So we were quite a while on our way. So she did also have some lung hypoplasia, of course. So we really wanted to close, but we said, no, we are not going to do that. And then next slide. So now we switched, and we were very disappointed on day 30, and we switched to Mapitel. I don't know if you use the same name, but it's a silicone dressing and a sterile gauze. And now she's okay. After we switched therapy, we could detubate her, extubate her on 10 days afterwards. And now she's on OptiFlow still, day 45. The enteral feeding was a full enteral feeding she had already during therapy with the duoderm. And now she's drinking herself a little bit. So 3 times a day she can drink for 5 minutes, because everybody was also a little bit afraid that she would forget how to drink if it would take such a long time before to start feeding by mouth. But now she's drinking like 20 mL per feeding, and she's really picking that up, and I think she'll be fine. So she has some kind of chronic hypercapnia, but today she was fine, and she had a CO2 from 8, so it's getting a bit better. And she also had a lot of medication during her intubation, so we were weaning her from medication. So I think that was the last slide. Yeah, so we had some obstacles during treatment. I think maybe we did something not quite as optimal as possible. But it was yeah, we still are very enthusiastic, actually. There's another one coming, and we really are going to do the duoderm again. But these are the points. Yeah, there were some discussion points, so I really want to talk about this. So maybe Miguel can
thank you, sir. I was taking notes about what the question that you were making, but let me show you. Obviously, we have experienced all that you experienced at the beginning.
Yeah.
All of them. And I can tell you more. Okay. But basically, just to summarize, I did some notes. When in the patient that were not first, I personally don't measure intra-abdominal pressure directly. I believe in clinical signs better than nothing, because if the pressure in the is 20 and the baby is doing perfectly well, everybody's happy. But the pressure is 3 and the baby is doing poorly, so it will change everything. So actually, I guide myself by clinical signs.
So second, can I ask you? So you press down just as much as possible until you see.
No, I wouldn't say as much as possible, but I try to move, forward, and I wait by the bedside how he is the next 10, 50, 20 minutes. Then I leave the room. So
Okay.
if I can see any, it's turning, like you said, the legs are turning blue, obviously I need to retrieve my progression.
Yeah.
And you can start sensing in the terms of how big, how stiff it is, how much pressure you can do, but obviously you don't put full stress in that. You make your judgment how the patient is. When you're not progressing enough, we definitely paralyze completely the patient. And we talked to the ICU patient, ICU doctor, and said, you need to give me a week of full paralyzation, because if not, we're going to be so. Obviously, we don't want them to be paralyzed, but if we're not progressing enough, we paralyze completely 24 hours for 7 days and then see how they develop this progression or not. We don't clean the amnios at all,
Okay.
and we change the whatever happened. We change the silo every 4 to 5 weeks because it loses traction, because it gets wet,
Yeah.
and it's the traction you need. Talking about how
Can I ask? So you don't.
Go.
So you don't clean it, but you only dry the skin.
We clean the skin.
Yeah.
That's all.
Yeah.
You can clean it the skin, but you don't have to. The
Okay.
thing you need to clean every change the skin definitely. So the traction of the duoderm is 100%.
Yeah.
Then how to prevent that the tongue depressor goes higher because of the pressure? Well, we experience exactly the same, and I can tell you, we still experience that in some kids. And we came with a lot of different, techniques. We flip the duoderm by itself. We put extra tapes, and we actually still having those problems in some of the patients. Obviously we don't feed them because we don't want any distension, and we don't go to the inversion of the amnios until it's completely flat.
Yeah.
Because we know it's going to be, it won't be good. You need to be completely flat, and then you can go to the inversion of the amnios. In terms of Botox, actually, we are going to start a protocol with Dr. Abello to see if we can put some in uterus Botox before they are born. And also, if they don't, we are going to start using Botox since day one. Actually, there's one patient already treated by this in utero, and in Colombia, we don't have any results to compare, but it went well. That's the only thing I can say. So yeah, we are progressing in the protocols, experiencing difficulties and how to avoid them or how to overcome them. But basically, again, the experience in the majority of the patient has been very, very good.
Yeah. Okay.
So, Miguel, if I may jump in there to start with the questions from the chat and our personal questions we have. Thank you both, or the three of us. This really very stimulating talks, and there are a lot of questions that we have. So, Miguel, the first question for you: your technique, is it more pulling or is it more pushing?
Or definitely pushing. You don't use traction to the ceiling. You put force into the abdomen. So
this lateral sides, they're not connected to the skin, that it's also pulling. No, it just stabilizes it and then you push, right?
Yes, that's right.
Okay.
All the force goes into the abdomen. You don't put the skin into the ceiling.
Okay, because there's this gravitas technique where you do multiple parachute sutures to the edge and then you pull, right? So this is
no, we don't.
Okay, good. And then there's another first question from Kalasha Atige asking, is it possible to do this technique with a non-thick or skin hydrocolloid dressing? Have you tried that?
Yes, yeah. We have seen those patients from other centers, and I can say that it may work, but definitely it's more difficult because of the traction of that duoderm is much less.
Okay, Augusto, you want to take
There's a lot of questions, some of course are repeating themselves, so I'll so first of all, in general, because a few people ask, and I'm sure you heard this question, why abandoning, well, what's wrong with the paint and wait?
There's nothing wrong. The thing is that I don't like to have a patient for a month or 2 months in the hospital send it home with a giant ventral hernia, and then come back in 12 to 16 months to have the surgery. If I can do it everything in majority of the patient in 1 month and send it home with everything just fixed.
That's great. The question was coming, for instance, from Ronnie Sfire from France, and he's saying, you know, we can have excellent outcomes in the province with pulmonary hypertension that 20 to 30% of babies with giant OMPHALOCELE experience. So keeping the patient ventilated and then doing, of course, a difficult surgery. It's very invasive for me, he says.
I mean, with our experience, I never did myself pain and weight. Since I started fellowship, I did surgical silos. So all the patients that I manage from pain and weight are older patients managed by other surgeons. And usually we get these patients when they're 2, 3 years old with a giant ventral hernia that we need to do 3, 4, 5 surgeries just to try to reduce it. So that's why I changed with this, because I really don't like to have a patient that maybe go away and come back 2 years later with a massive ventral hernia.
Okay, then there is a question about the mesh. You mentioned you put a mesh or patch. What mesh?
In 4 patients, we put a bical mesh over the primary closure just to reinforce the closure. And usually in patients have done a component separation. And in only 1 patient, I put a Gore-Tex mesh just to close it because it was too tight. The other thing I want to mention, Martin, is that this has to be very thoughtful talk with the NICU doctors. They hate to have those patients intubated for nothing, and they need to understand what's our goal. And obviously, we set time frames at the beginning, saying that within 7 days we don't do any progress, we're going to change, because obviously you can't have a baby intubated, they're not progressing to our goal to that's the reduction. So you need to, I think, and with the nurses about how handling the duoderm also. So we talk a lot with all the NICU doctors and the nurses just to start this program.
Okay, but you can, as if I understand you correctly, you can always fall back to a paint and weight technique.
Yeah.
That's what you want to say.
You don't cross any bridge doing this at all. At all.
Another technical question, Miguel, for you.
Oh,
It's
sorry, Augusto, sorry. And we have all talking about crossing bridges. We have 3 patients that they were born with the amnios rupture, and we suture it and then put the silo on top of that.
That was one of the questions about rupture of the sac. Another one is from King's College Hospital in London. They've had recently a patient with exomphalus major, with a narrow neck, and so a mushroom-shaped defect. Do you think this technique would also work for those kind of defects?
It depends how they progress. I remember 2 or 3 patients that it looked at it, then they were never going to be. Again, those patients 10 years ago, I will put a surgical silo and extend the base hugely. In this patient, you start and see how you progress. If you don't progress at all within 7 to 10 days, you change your approach. That's it. So again, you don't cross any bridge starting this.
Yeah.
Okay, and then I wanted to ask this component separation that you mentioned. I think component separation is a great technique, and Marlinde mentioned during the first webinar, René introduced that, and I tried that on several patients, and it worked great when they were like 1 or 2 years of age. What is your experience in the neonatal age? I've tried it once in a neonate, and it was not so easy, because it's not so easy to find the right plane and avoid getting too deep and then not separate only the anterior component, but several, and then you have another hernia on the side. What is your experience with a component separation in a 1 week old?
We have done 3 patients with component separation with between 2 and 4 weeks of age. And Actually, they went very well. We haven't had any, hernias on the side or whatsoever, or any complication because of that. I reckon that it could be difficult to identify exactly where to go and how deep to go. I think that maybe in the first two, we were very shy. We can say that to do it. But the last two, we did a full mobilization, and so far they went okay.
Okay.
The first cases, though, I did it with a plastic surgeon that was very, very, had a lot of experience doing those in bigger patients, obviously, and we did with them.
And then there's another question from Ian Tsai asking about the different phenotypes of the giant OMPHALOCELE, and he's referring to this bottleneck kind of style. And can you apply the non-surgical silo there too? That's his question.
Yeah, we started. Yes, you can start if you don't progress within 5, 7, 10 days, and there's nothing you can do about it, and there's no progression. Even the patient is completely paralyzed. You need to switch to another technique. That's all. Again, you don't cross any bridge, and you go to pain and weight or surgical silo, whatever you want. But so far, even we saw this patient, about two or three of them within this series, we haven't had to change it so far.
There's a question to a little bit of everyone. It's about a pulmonary hypoplasia in babies, of course, with OMPHALOCELE, and we know this is associated, but is there specific criteria to determine the severity of the condition? Like, in the CDH, you have the LHR, and there's other parameters too. So is there specific criteria to determine the severity of the condition to decide if it is contraindicated for a reduction procedure? Or is it simply a matter of trial and error based on the baby's tolerance to the procedure?
With the first patient that I mentioned in our series, my series, that this was 880 grams with the cardiac condition, we just put the silo and did nothing for the first 5 days because the baby, again, I touched the baby and he wanted to die. And because of the cardiac condition and the pulmonary hypertension. Then on day, I think 6 or 7, he stabilized, and then we start slowly, very gently, very little, pushing, and see how the patient responds. Again, there's no numbers in terms of if it's 20, 30, or 40, the pressure. I think is how the patient responds with every, pushing back the silo.
But I think
I see that somebody asked if this could be a technique also for gastroschisis, and you already answered that this is not for gastroschisis.
I would never.
Obviously, would be you have the organs exposed. I would be worried that the duoderm.
I mean, you can do it, but you have to put something in between. That's for sure. So
exactly.
Yeah. But Miguel, I put our paper in the chat on a ruptured OMPHALOCELE where we put an Alexis XS wound retractor in there and then treated it as a gastroschisis. That works also.
Yeah, I agree. We have done Alexa in gastroschisis and works marvelous.
Yeah. So, but coming back again to the pulmonary hyperplasia, we had several patients, and one actually went into lung transplant 1 year after he was born. And the median, according to the literature also, if they have lung hyperplasia and are on the long term on the ventilator, the median time of ventilation is 100 days. And that's also our experience. We had patients who were like intubated for 10 months.
Yeah,
if they have that, that's a real problem. Then the abdominal closure is actually not the biggest problem of that child anymore, right?
I agree. I mean, in those patients, you have to go very slowly and see how they respond. That's for sure. You don't. I mean, again, this is a trial error for each patient. There's nothing they're going to say each patient will go 1 centimeter a day. We have patients that we can reduce 2 centimeters every day, and some do 1 centimeter a week. It depends how the patient have the comorbidities, how they develop, hypertension. So this is a trial and error for each patient is different. Although the protocol is the same, the timing and how to progress, you have to assess for each patient.
I have personally a patient that is where I'm being waiting, is 2 years old, the giant OMPHALOCELE, but also Morgagni hernia, quite sizable Morgagni hernia. So I, of course, painted, and I'm waiting to then repair. It's now off oxygen. It's at home, but it was on oxygen. So I've always been a little nervous of thinking of pushing things down that then will come up in the chest.
Sure,
And
of course,
my plan is to close the diaphragm at the same time, and still, worry that the diaphragm can open up. So of course, every patient is different.
Have you using Botox in that patient, Augusto?
I'm thinking of it.
Yeah, I think will be a great candidate for that.
It's a good, yeah, absolutely.
Yeah.
There's a question maybe for Marlinde or Hester. Who to contact if we wish to conduct a multi-center study or trial in Africa? Now, of course, Ernica, as we said, EUPSA goes beyond the borders of Europe, but I'm not sure if Ernica goes beyond the borders. But I'm sure there's been a lot of multi-center studies, for instance, also during COVID, started from the Netherlands, as well as other countries that have included also countries in Africa. But do you have an answer?
I must say it's a very interesting question, and it would be very interesting to conduct a study like this also in Africa. So feel free always to contact me or I think Hester as well. I don't know about the other ones, but yeah, I think it's very interesting to discuss this. So I think all of us would be open to discuss this at some point. I can put my email address in the chat one more time.
Thank you.
So, but that leads me also to the question of that cost. Miguel, you said it's not very expensive. I just Googled it on Amazon. 5 by 10 centimeters of that device is like 20 euro. So on your picture, I saw maybe you need 3 or 4 to wrap that up. How often do you change that? So what is the overall cost in terms of material for maybe low-income countries in Africa? Is that feasible, or?
Yeah, I mean, it depends. And some patient needs only 1 20 by 20 centimeters. Some of them needs 2, and we change it every 4 to 6 days. And if you think that the patient 95% can be done within 2 or 3 weeks, so it's not that much money.
Okay.
Obviously, you need to keep the baby in the NICU, and that costs money every day on top of that. But in terms of materials, it's not that much.
And
there's a question from Bip Nandi that I know from my training years in the UK. Says, hello from Malawi. Thanks for a great talk, Hester. I learned so much from people's difficulties than from their success, and I think we all agree on that. Also, this was your #1 patient, so I think it's I wouldn't consider it as a failure. And then to Miguel, is it possible to use this technique without ventilation? After amnio inversion, what happens if you keep a dressing on and don't do surgical closure? Did you have ventilator paralysis, TPN related complications? And finally, maybe a foot clip might provide more uniform pressure and prevent the migration that Hester experienced.
The thing that the baby is not sedated, it will keep putting pressure on, and if you start feeding the baby, it will distend the bowel. So it will be very long if you succeed. I mean, we have seen this in another patient that if the patient is still coughing and moving and putting a contraction on the abdominal wall plus feeding, I don't see this happening in 2 or 3 weeks. It may happen maybe, but maybe in 2 or 3 years. So definitely to be successful in this, you need to be at least the patient needs sedated.
Then there's a question on an alternative technique. Maybe they can combine, from Jorge Oliveros, asking about negative wound pressure, like a VAC. Have you ever added that, or have you ever tried the vacuum dressing on OMPHALOCELE? What is your experience?
Not in OMPHALOCELE. We have used a lot of time the VAC treatment, but not in OMPHALOCELE. We haven't yet so far. I'm not close to think about it.
I had N times 1, and we wrapped it around the entire child, and then the legs went blue, and then we removed it the same night because it was just too much force. But that's just one page. Maybe we did it wrong.
Somebody is asking about hiatus hernia. I don't know if you've had how many cases of a hiatus hernia. So maybe they're worried that with this technique you're pushing things too early into the abdomen, and maybe this can result into a hiatus hernia.
If they have did, I don't think nothing in the series that no, not that I recall. No.
There's the question about the protocol for Botox. And I also asked myself, usually that does not kick in on the same day, right? If you
no,
do
it usually takes at least 4 to 6 days to start kicking in, and the peak is 2-3 weeks.
And how many units do you use? Like
I don't know exactly now, but we use like, you know, I don't have it in my mind now, but I can send you the protocol. We start with this protocol in utero and ex utero. And I don't have the number exactly in my mind now, but this I can send it after. But yeah, we have the protocol for, you know, starting since birth. We're going to start using it on day 1.
Yeah, maybe Gaia can share it on social media, and then we can discuss.
There's another request of participating in a multi-center collaboration study from Ethiopia. So definitely this is a recurring theme, and of course EUPSA is very open to this, and we can definitely something that can be also taken up to the network office. And I think that we are well beyond the hour. I think it's been a fantastic presentation from all 3 of you. The great thing of having, of course, the expert, the novice in a way, a case. This was a fantastic, I think, for the upcoming patient, you might consider sending a plane ticket to Dr. Guelfand to come to your center. Sometimes it's much cheaper than many other things.
No, but Augusto, I can tell my experience with, there's 2 other centers here in the US that start doing it in Boston and nationwide. And for the first cases, we, connect obviously virtually. And that was a very good experience for them to somebody, in the room, to the little tricks. And actually they adopted the technique for the last 2 years. They are very happy with that. So happy to help with the air ticket plane or by virtual thing. I'm happy to do it.
Fantastic. I think, I don't know if Marlinde, Hester, do you have any things to share more than what you've shared?
I just want to add that we're just very happy that it was possible to get into contact with Miguel Guelfand, to hear from him all his experience and his expertise. And we're very excited to analyze this technique in Europe. And I think especially this patient case shows that it's important to see how to use this technique and to perform research on it. And it's very promising. So I'm very excited about this. And thank you very much again for the opportunity.
No, thank you very much, everybody, for the invitation, and happy to be among friends, basically. So thank you.